Okay, as I said, we'll send out the invitation for the hackathon this week. Make sure that you take advantage of the fact that you have early access to the participation. We anticipate that the spots will fill up quickly. Unfortunately, we have to limit the number of registrations as we only have limited resources. So make sure you jump on that as soon as we send it out to you via email. And then as usual, we'll have a Gather Town meeting after today's talk. If you want to stick around and talk to each other or talk to us, that's an opportunity for you to do so in a friendly little virtual environment.
Oh, you're not sharing your screen, by the way.
Oh, am I not? How about now? Wonderful. Okay.
Oh yeah. Okay. Luca, maybe could you just let Reza in if or send him another email about the passcode. Okay. So we have an announcement. If you do remember our week 2 speaker, Dr. Renata Radu from UT she told us about a PhD position that she'd like us to advertise. So Dr. Renata Radu has an open PhD position in biomedical visualization and visual analytics. And she is from the research division of computer graphics, Institute of Visual Computing and Human-Centered Technology from UT in Austria. So on the left side, it is more information about this application, and the deadline is on July the 29th, 2021, and that is Renata's email address. We are also going to send everyone an email about this, so that you can consider it yourself, or if you know someone who might be interested in this position, you can refer it to them as well.
Yeah. And then hopefully we will get our speaker to be able to join very soon. But today is week 5 of McMed Hacks, and we are very happy to have Dr. Forghani here as our speaker, or hopefully soon. And I will just let Eugene do the land acknowledgement.
Yep. So, sorry, everyone. Dr. Forghani seems to have a little bit trouble joining Zoom right now. We're trying to solve that right now. So, land acknowledgement. We do this every week, but we think it's very important to emphasize this every time. So, if you do not know what land you're on, please click on this. You can click on this link for everyone. We're going to share this slide with everyone as well later on, so you can take a look. To see which land you're on. So our virtual event today is based in Montreal, Quebec, in Canada, which is the traditional territory of the Kanaka, and is on land which has long served as a site of meeting and exchange amongst Indigenous peoples, including the Haudenosaunee and Anishinaabe nations. We acknowledge and thank the diverse Indigenous peoples whose presence marks this territory on which peoples of the world now gather. And we encourage you to learn and discuss more about the history of the land on which you reside. Thank you.
The rules for participants, as usual, you guys have been really great about this. Just be respectful to each other and the staff. In terms of questions, direct them into the Discord channel. I will show it again here really quickly. So we ask that you please don't unmute yourself during the presentation, but ask questions in the designated text channel, or wait until after the presentation to ask your questions then. Yep.
All right, so
go ahead.
Yep. So we have another 2 mentors this week, Serveth and Isabella. Are you guys here? If you guys are here, you can unmute yourself and try introducing yourself a little bit. But if you're not here, Luca and I are gonna introduce you instead. Luca, do you want to? So
trying to see.
yeah, there we go. Isabella's here. You can maybe say hi to everyone.
Hi, I'm Isabella. I go to McGill. I'm in my 4th year, and I am minoring in computer science. I'm very excited to be part of Macaxis here.
Thank you.
Hi everyone, I'm Sarvaz, and I'm a U2 at McGill, and I major in computer science with a minor in statistics.
Awesome. So those are our 2 mentors today. They will be trying to answer any questions you have, or relaying those questions to us during the Q&A session. They'll also be making the assignment for this week.
All right. Now it's I see Reza, you're here now. Now it's my greatest honor to introduce our keynote speaker today, Dr. Reza Forghani. His talk today is going to be about artificial intelligence in medical imaging, image-based biomarker, and beyond. So Dr. Reza Forghani is a diagnostic radiologist and clinician scientist. He completed his MD and PhD degrees at McGill University with a PhD in molecular and cell biology. He also completed his residency training in diagnostic radiology at McGill University, followed by a 2-year fellowship in diagnostic neurobiology and neuroradiology at the Massachusetts General Hospital, Harvard Medical School. And currently, Dr. Forghani is currently the Director of Augmented Intelligence and Precision Health Laboratory of the Research Institute at the McGill University Health Center, with interest in medical applications of artificial intelligence, advanced imaging, and integration of multi-dimensional data types for precision healthcare. So if you attended the last 2 of our workshops, you may have seen Farhan Maliki, and they also work at the same lab. So it's our greatest pleasure to have Dr. Reza Forghani here. And yeah, see, he already unmuted himself, so maybe you can say hi, and we're gonna leave the floor open to you to start your presentation. Thank you so much.
Hi, everybody. Do you see my slides?
Yeah.
Okay, perfect. Well, first I would like to thank the organizers from McMetax for putting together this great program, and also for inviting me to speak. So I will talk to you and give you a general perspective. What I'll try to do, and some of this may be familiar to you, I don't know, depending on the audience, the degree of familiarity, but what I would like to also confer to you is also a more medical perspective and more operational perspective to some of the work that you're doing. I do think, we have a true multidisciplinary lab. As you know, you have met some of our postdocs, that we truly have a lab consisting of both physicians, basic scientists, computer scientists. And if you want to make things that are used, you have to understand the whole spectrum. That's why we are multidisciplinary. So I hope in that sense, the talk will be of interest. These are some of my disclosures. So what I'll do, and again, depending on your degree of familiarity, so what I will try to do today is just a briefly overview quantitative image feature extraction and AI as it pertains to its use for as biomarkers and for prediction model construction, which is really what's of interest to us. I will talk about texture analysis and radiomics. And again, there is divergence in the literature if you follow the computer science literature versus the medical literature and how some terms are used. And I think it's important to understand that, so to understand the commonalities and where people are going, separating. And we will discuss some select applications that are there or are upcoming, focusing on a few examples I picked from neuroimaging, and maybe just very briefly touch on some future horizons and challenges. So probably not a surprise to this audience, but sometimes for a more general audience, I'd like to remind people that artificial intelligence is a broad field. In computer science, you would know that. Really, in medical applications, we are largely talking about just one of the subfields, which is machine learning. We're not limited to that. Natural Natural language processing is also playing increasingly big role. And indeed, NLP itself has evolved so much. It did not utilize machine learning before, and now it uses so much. But nonetheless, to put in perspective, there are many other branches of AI. And of course, deep learning, which did generate a lot of excitement in AI, is a subfield of machine learning. Now, when we talk about image-based biomarkers, and we really talking about quantitative features that are extracted from various medical images, medical imaging is really at the heart of most major diagnoses right now, right? And one of the interests there is that there's more information on those images that we are utilizing. And in that sense, there's been lots of interest. And in that sense, both computerized image analysis and AI have a great potential role in future healthcare delivery. Now, just, when we talk about extracting features, this is the example of a brain tumor, so we want to extract some features. Of course, right now, these images are evaluated by experts. There are a number of things we can determine. These are used to actually provide a stage, often depending on which body part, which is used to guide management. But there's really a body of evidence accumulating that the finer quantitative features, some that we do not use as experts routinely, or maybe are not even clearly appreciated by the human eye, have predictive value. So this is where the interest comes. Now, especially for those of you who may not follow the medical literature, I do want to clarify things between texture and radiomics, because it's funny, there are fields that are almost the same, and sometimes if you read the medical literature, it seems you get the impression they're working in parallel or they're separate things, right? So if you go to texture analysis, your definitions vary. Here, I took a definition from one of our clinical journals, one of the journals used by a lot of radiologists, which refers to texture, objective quantitative assessment of tumor heterogeneity based on the analysis of distribution and relationship of pixel or voxel gray levels in the image. And, I think one thing, getting back to it, obviously, when we talk about these features, some of these are very simple. By the way, some of these we do use in practice. For example, if you're interpreting a CT scan, sometimes we will measure density, which is an average, and you see a standard deviation to try to distinguish certain types of tissues, like simple fluid, right, from a solid tissue, from hematoma. So we do use them. But of course, texture, if you want, we're going to go beyond texture, and radiomics goes far beyond that. It also tries to quantify other relationships on the image that are not reflected in those basic first statistical features, such as average and standard deviation. And, an example, again, I'd like to at least show our clinician colleagues often, is that, if you look at these two squares, they really have, let me see if my pointer is visible. Let me make my... I'll make my pointer visible all the time in case you can't see it. Here, okay. So if you look at these two different squares, to the eye, these are clearly different, right? But I can tell you, if you take the average or standard deviation, they're identical. And in the simplest way, this is what, beyond all the complicated definitions and everything else we talk, this is really what we're trying to capture. And whether these differences, this spatial quantitative heterogeneity, has predictive value, because studies are showing that there are associations with outcomes of interest, such as tumor molecular features or recurrence. Now, radiomics, this is a definition that was introduced in the literature in 2012. And it was initially defined as high throughput extraction of large amounts of image features from radiographic images. In 2016, this definition was expanded to read as conversion of images to higher dimensional data and the subsequent mining of these data for improving clinical decision support. I actually like this because if you go in the biologic fields, right, and I don't know how familiar, sometimes there's not enough interfacing. We always talk about, big data, large genomic data. Images were essentially never there. But there's a lot of information on those images. A lot of this doesn't really require an invasive procedure, so why would you not use it? And I like this because it takes us towards that. I also like it because, as some of you probably know, texture in computer science has a very specific definition, right? And although some doctors use texture to essentially refer to all these quantitative features, I'm sure your group knows that they're not, right? So maybe in this case, and also not all image analysis is AI. Again, maybe obvious to this group, but sometimes this is not clear. So when, and I think it's important for you, especially if there's a large body of computers. Obviously for the medical people, they need to understand this. But I think on the computer science side, you also need to understand this, because this is how a lot of the experiments that are being conducted are thought about, designed. So you need to understand how they're approaching this and how these things have to be unified, right? So one thing that we want to do is that not all image analysis is AI. And indeed, a lot of things that could be useful are not necessarily AI, right? It's a combination. It may seem obvious, but sometimes I think it's important to highlight that, because there's also lots of hype with AI. Now, if we take a step back and just think about image analysis and not the prediction models, maybe broadly you can define these as handcrafted radiomic features, right? Things that are, if you want, mathematically explainable, usually really designed before the experiment. That's probably the best. There's no completely agreed upon definition, but that's what it would be. Versus another whole class of features that have become possible now, especially with deep neural networks, is that these are deep radiomic features that are extracted and used for prediction modeling. And of course, the latter is not it's not designed before the experiment, right? It's the opposite. It's actually learned and then used. Now, if we go to summary of what we call, let's say, handcrafted quantitative features, so non-deep learning extracted features, there's a whole categories. I'm not going to go through these. I think this crowd is probably very familiar. But what I do want to sometimes, especially for the more medical, for those in that are on the medical side, point out that at least in the computer science literature, texture matrix-based features have a very specific definition, right? This is why, in a way, I think if you search the literature, you should look for texture, because there's a lot there. But I don't like that, because a lot of what they refer to as texture is actually includes all of these handcrafted quantitative features. So just keep that in mind when you're evaluating the medical literature. But really, at the end, you're talking about images extracted, features extracted from images using computerized image analysis, right? I think radiomics is a good general umbrella term. This is something that's going to be expanded. It's very general, so it's good. So as we come up with new ways, whether they are handcrafted or whether they're deep features, they could really all fall under this umbrella. And also to remind that the features themselves, indeed handcrafted features, are not AI-based, right? And even though one, I guess, may assume that with sufficiently large data sets, deep learning would have it all, we have to keep in mind that this is not proven, at least not in medicine. Now, we have not had the large sets. And if you look at some of the smaller studies, actually, there's complementarity, there's a question. So this is still something that will have to be proven before you completely dismiss. And of course, you would have to have large enough data sets, right, to be able to go really solely towards deep neural networks. Now, once we have the features, so these are things extracted from the images, the next step is going to be machine learning, right? So why is machine learning interesting? Because if you think from a clinical perspective, okay, we have an association between, let's say, a quantitative feature that you have worked very hard to design and an outcome. That doesn't really translate into a way we can apply to a patient. Now, why is machine learning interesting? Because it can give a prediction the way we function in the clinical arena. It can give you a sensitivity, a specificity. I always like to remind both my clinician and non-clinician colleagues that most diagnoses are probabilistic at the end, right? There is no 100%. And in that sense, machine learning is nice because it gives you outputs that you can more easily take into the clinical arena. And of course, compared to traditional software, there's the other part that machine learning has the potential to improve with time. Now, that's the opposite of most basic software, that with time, they tend to just not function as well, right? So that's a great potential. But to remind the audience that at least in the clinical arena, right now, there is no machine learning algorithm that's a live mutating algorithm, right? And you can understand for practical and safety reasons. So even the AI applications that are approved, or let's say FDA, Food and Drug Administration cleared, they were trained with deep learning, but once they're implemented, they are static. And I mean, you can't even blame them. Again, as computer scientists, you may want to think about a future where maybe the algorithms have some room to improve with time, but then you have to address, how would that be regulated? How can you make sure that the software is not malfunctioning? Because this is not theoretical, right? You're making someone's diagnosis. You can give them the wrong treatment. You may kill someone. So you can understand, and again, these are layers of things that are challenges, but they're also opportunities for you in the informatics and computer science field, because this is just growing. So you can see how all of this comes. So going back, this is the attraction of machine learning. Now, we talked about image extracted features. That's one part of the equation. The next part is to use machine learning to construct a clinical prediction model. So that's the way most clinicians are going to be interested in this. This might be to predict a certain molecular endpoint, certain, I don't know, molecular phenotype that we couldn't predict, response to treatment, something that is clearly of clinical interest. You see how that can be interesting. And by the way, that can be done using more classic machine learning approaches once you have the features, or it can be done with deep neural networks, or it can be done as an ensemble. I mean, these things are to be settled. These are all possibilities. I do think it's good to, again, separate these, because sometimes there's, in the hype of AI, sometimes we confuse everything that's informatics with AI. And of course, you know, that's not the case. And indeed, to do AI, you need good informatics. You know, yeah, you need a good infrastructure. So just keep that in mind. But this is where the power goes. Now, if you go in the medical literature, actually, there's a lot of studies. So, you know, next time you do search of pathology, make sure you put keywords like texture, like radiomics. You will get separate set of articles, even though you should really be getting the same. And they use the handcrafted features a lot for a reason that's probably obvious to you. With small data sets, sometimes the results we get in pilot studies are going to be more reliable with handcrafted and classic machine learning, because, you know, a deep neural network may just not do that well with 150 data sets, right? And of course, a lot of these are not whole image analysis. And this is something we want to change over time. But for the foreseeable future, you are going to see investigations that, like our investigations, typically include both. And I think that's what you're going to see until we have sufficiently large data sets, which are not easy to get in healthcare, complexity of disease, privacy protection, ethical issues, all of that. So until then, this is probably going to be a good body of work that's done. So keep that in mind when you design things. Make sure you look, and of course, look for solutions in the future. Now, I think this is, for this talk, we don't need to talk. You're all very familiar with what's classic machine learning and deep neural networks. And of course, before we go on applications, you know, something that, depending on how actively you're involved, to remind persons that the machine learning and, you know, things like deep learning are definitely exciting. That's what generates the excitement. But when it comes, whether it's to designing an experiment or practical implementation, I mean, that is usually, I don't know, 20% of the effort, 25% of the effort. That's not the challenge right now. We hope to change the infrastructure to change that, but think of it. What are your bottlenecks? You know, getting the data, getting your hands on the data first, right? Labeling that data, curating that data, labeling that data, having labels that are reliable. And by the way, all of this affects what you have. For example, in the machine learning community, and for good reasons, there's a lot of interest in open data sets. And I understand that, because you can then access, you can validate. But even that, you have to keep in mind, a lot of good healthcare data cannot be made open. There are ethics reasons, regulatory reasons, and financial reasons. So I would encourage you not to just rely on those. Also, a data set that has been made open is likely has significant biases by the process of, by the sole fact of making it into that process. So just keep that in mind. And I don't need to tell you, bias is a major thing. What do we do for our algorithms? Generalizability, right? Don't have exclusions. Good luck finding, maybe in something very basic, you'll find one, you know, like definitely there are some institutions that just consent everybody, very good practice. And they can release large data sets, say, of x-rays that may not be biased. Even that, by the way, has a geographic bias. It has a referral bias, because most of these institutions tend to be sort of quaternary care or tertiary care institutions. But other data sets are completely biased. And you know the importance of that in terms of potential impact on algorithm generalizability, right? For example, let's take head and neck cancer. There are a number of open sets. They're good sets. When it comes to, by the way, but if you look at a lot of those sets, for example, there's a bias towards tumors that were treated with radiation therapy, right? Oropharyngeal tumors. That's already a major bias. You're essentially, so if you take mucosal head and neck malignancies, you're already excluding a whole set, oral cavity, like a whole gamut. Why is that? Actually, a lot of that is practical because in radiation therapy, they contour. So of course, it seemed like a great way without putting the extra burden of labeling or segmentation to share data, but that has inherently biases in terms of the population you're getting. So you just have to keep that in mind. And this bias is like to exist with most data sets. I would even take it then one step further. When you have contours shared publicly, are they really expert vetted? So even, by the way, if you take something like head and neck cancer, even if you take the top experts, you're going to have a small variation. But if you go beyond that circle, I can tell you your variation is going to be large. In the radiation therapy literature, I know there are variations of 50 to 60%. Now you're relying on those handcrafted features. You got to realize that there are lots of unknowns there you're taking for granted. So this is not to discourage you, but I think it's important for you, especially as computer scientists, to understand that some of these things that seem so absolute, oh, they were used for patient treatment, so that's it. Actually, they're not absolute at all. Again, in the long run, this is what the most exciting is when we have sufficient image numbers that we go to whole image analysis with deep learning. You're going to overcome a lot of these, right? Because then you don't have those biases. And then you tie to an actual outcome that is not questionable, like survival or treatment response or recurrence. But in the process of getting there, these are major biases you need to keep in mind. Now, to really end the talk, I'm going to go to a few neuroimaging applications. You know, we do a lot of, we don't do exclusively oncology work, but there's definitely lots of interest in precision oncology for radiomics and applications of machine learning. This is a review I wrote a couple of years ago. I know the applications have already expanded, but just if you take brain tumors, you know, there's a whole number of studies suggesting we can help classification of tumors using imaging, that is predict histopathology classification. Not too bad, huh? Because for that, you need to cut the person up. You have to take the tumor out. There are important studies showing that you can but these are very preliminary, differentiate something called pseudo-progression from true tumor progression. For example, if you take brain tumors, this is a major challenge. Sometimes on imaging, things look worse. And one of our challenges with those is that true recurrence, or is that radiation therapy change, right? So there's preliminary studies that are showing that radiomics and machine learning can help in that. There's a number of other things. There are a number of studies showing that we can actually, with a reasonable accuracy, predict molecular phenotype. And then this can have, as you can imagine, treatment implications. But these are preliminary, but they're there. And this is really what causes interest. I can tell you, for us, we are doing something right now. We are overseeing a project trying to predict brain invasion from metastases. This is one among many projects, which could definitely have therapy implications. Now, I would argue that at this point, the idea that this value is pretty much there, right? I don't think that's up for debate anymore. So the next step is really, are these consistent enough to be applied? And how do we do them? And I will try to get that across, because I do think that's an important step that if we do not do, a lot of these things are going to remain theoretical. And again, this is the audience. You're the ones who are going to engineer these things. You're going to work with your clinician colleagues. So I want you guys to see the horizon. But what's nice is there's a lot of opportunities for you, right? So learn healthcare. This is going to be an expanding field. I do want to mention a couple of things. You know, there is this thing, you know, I mentioned already that there's data we can predict molecular features. Now, I don't want anyone to go away thinking that, oh, you know, just by non-invasive imaging and computerized image analysis and AI, we're going to not do pathology. It's not going to happen, right? On the other hand, the frontiers of imaging continue to expand. If I take you back to a time, probably many of you weren't born, You go to what, 70s, 80s, you know, we barely saw anything. People would do x-rays, try to inject things into people's body to try to predict if there's a brain mass. I mean, that's how it was. Come to now, we have pretty much mastered anatomic imaging. I mean, we can see inside the patient's body using CT, using MR, we can measure the tumor. So we've really come a long way. And the way I like to see this, and a lot of that was on the hardware innovation side, right? Scanners, MR technique, CT technique, probably our next revolution in imaging. And by the way, imaging has changed your life. That's why you don't get unnecessary surgeries for appendicitis. You know, that's why you know the surgeon knows where they're going before they treat the tumor. Now, what is likely going to be our next revolution? Actually, personally, I think it's going to be informatics. Computer, this kind of stuff is what's the next revolution. And we are going to push this frontier to start to go a little on the molecular side, you know, trying to associate features reliably with certain molecular features. And at the same time, pathology is going to expand their frontier. You know, they're going to do more robust analyses. They're going to use machine learning. So it's not that we're going to replace, we're all pushing the boundaries, right? And I think that's the nice way to see it. And, you know, when it comes again, things like surgical guidance, you know, imaging and AI could be very interesting. Because there's a lot of tumor heterogeneity. Indeed, that's the basis of a lot of this work. And can imagine having a system that tells the surgeon, hey, I think you need to go here to get the highest grade of tumor. Because if you sample this part, guess what? You're going to underestimate a tumor's aggressivity. And that I see potential. And there is one advantage that imaging will have over pathology. You see the whole thing. Anyone, and I go to the pathology suite, so I probably see this much more than most radiologists. There's a major thing about sampling bias in pathology. That could be where you biopsied, and that's the fact that, well, unless you resect the tumor, so pre-treatment, you don't take out the whole tumor, right? So you may not have a full picture. By the way, even if you take out the whole tumor, there's only so much resource. So you only analyze the whole thing to a certain extent. So just keep things in mind. And these are ideas of where you can work in the future. I want to, before finishing, just briefly talk about a couple of applications. One is ischemic stroke. As you can imagine, stroke has a major burden on society, okay? And in terms of ischemic stroke right now, my colleagues at the Mass General, that's where I train, have come up with an algorithm that actually has the potential to surpass that is very good. Let's say at detecting infarcts on CT. Now, Mass General Hospital is very uniquely positioned. They're a referral center for stroke. They actually have an MRI in their emergency department. So they get to do MRI for every stroke. So they really get gold standard stroke infarct volume before we can see on CT. So they're uniquely positioned. And you know, them and other groups are developing these algorithms as diagnostic assistants for evaluation of stroke. Now you can see the potential of this, right? So this is no longer theoretical AI, this is applied AI. And once this happens, especially in something like stroke where diagnosis is time sensitive, you can imagine how this can impact. Indeed, if sometimes in a remote area, because some of the stroke therapies are time limited, even 2 to 3 hours of saved time could be the difference between getting a certain treatment and not. So lots of excitement. So, you know, a lot of AI is still in the theoretical space in healthcare. But guess what? It is coming more into a practical space. AI can also be used to do certain things that we don't do because they're too time consuming, you know, such as volume segmentation. I mean, do you believe it? Still, look at how we follow tumors, 2-dimensional measurements. You say, why? That makes no sense, right? But practicalities matter. Another thing, I think as computer scientists interested in health, I really advise you to understand healthcare. You know, there are logistical barriers to healthcare. There are actually emotional barriers to healthcare. You know, people, you know, when it's your life and death, people look at things very differently than the way you might look at it. And I think you'll have a hard time designing things that people use unless you take this into account. On the other hand, this is a true possibility. And I would emphasize that practicalities really matter. Practicalities is why a lot of good things don't get used every day. Because at the end, by the way, you go to ER, you want your scan read, right? You want the emergency condition diagnosed. You wouldn't want someone to go spend 1 hour contouring something for a less clear benefit. If you don't address those things, won't be used. But automation, semi-automation has really the potential. And again, going with things like stroke, you know, there are algorithms now, some commercial, that can detect large vessel occlusions, again, accelerating diagnosis. So this is one example in neuroimaging that, you know, I really see coming. This already, by the way, is already sort of there. And right now, lots of groups are doing very exciting stuff. Some undergoing regulatory process, some already cleared, which are going to have lots of impact. Now, going, of course, for us as radiologists, the whole range of practical things, work list prioritization, and other things that are even lower hanging fruits. They can make healthcare as a general more seamless, perhaps more cost effective. So these are other areas. I mean, we don't have time to cover them, but we're thinking about, right? It's not just about the diagnostic assistant. I would say that is just one part of it. One area that interests us is eventually, of course, can be mixed image-based features with things like molecular features, circulating tumor DNA for more precision diagnostics. Very interesting. Just again, to think of the circle of medical care, you could pretty much envision an AI-based process for any of these. And some of these won't even be subject to regulation the way diagnostic tools are. So for those of you interested in career in informatics and health, just think about these. All of these things I'm highlighting here, there are sore spots there. Your expertise can help. It will make the practitioners more safe, more accurate. It will make them more efficient. It could potentially make the healthcare enterprise more efficient. So these are, you know, again, these are big topics, but things to think about. How do I foresee in imaging what we may do right now? Our reports are very basic, right? They're not basic. Look, I mean, let's be honest. But from my perspective now, in what's possible, they seem basic. So sure, we evaluate a tumor, we give two-dimensional measurements, we give some observations. Does it look necrotic? And then, you know, depending on the body part, let's say in head and neck cancer, we'll say, where does it go on? That's used for stage. But we really stuck to anatomy, and you can foresee, and I think this is feasible. If we can make these tools implementable, you can foresee in 3 to 5 years, reports that not only have two-dimensional measurements, but volume routinely. And indeed, perhaps they can give you a probability of a molecular phenotype, let's say for brain cancer, or treatment response. And how important would that be to avoid a toxic treatment that's going to fail and institute the right treatment just based on the non-invasive diagnosis? So this is the potential. This is what you're working for. Now, I said a lot of good things. I don't want to finish by saying this is a done deal, because it's not by far, right? Lots of challenges, especially when it comes to handcrafted features, technical variations, and reproducibility. I'm not as worried because most of the major journals, the people who do this work now are aware, and they're designing to overcome these. Even data harmonization, and I'll give you one of the most basic examples. Let's take a basic blood work. Do you realize that the normal range is gonna have variations depending on your lab? I mean, think of it. If you can do data harmonization, you actually have to take these things into account, that lab in system A has a normal range that may be 5 points off or different from lab in system B. So these seem simple. And to a human, by the way, oh yeah, I look at the normal range, boom, done. If you're trying to come with objective quantitative features, guess what? These become issues. So think about these. But again, opportunities where you can help this become reality. Large and varied data sets continue to be our biggest challenge. This is what we need to work about, right? Not have bias. Data sharing and ethics in healthcare is a challenge that's there, and it's going to be there. And this is something that probably really needs almost government engagement. And we have to decide in some points as society, where do we reach that balance that we protect everyone's privacy, but at the same time that, especially in a public system, that the data can be used to improve the health system. But what I guarantee you is you may have no interest in ethics or law, but if you don't address some of these fundamental blocks, you'll never get those large enough, varied enough data sets that will help you make good algorithms, at least not for a lot of complex conditions. So do not dismiss these. And what some of these often lack is expertise. Your expertise will be appreciated. You know, what is secure? And of course, think of security. And lastly, practicalities and seamless workflow integration. You know, it saddens me that a lot of things we use, yeah, sure, the deep learning is relatively new. Some of the other ones, they're really not new. Computer scientists have been doing cool stuff all along, but they never worked with people who use them for someone to point out, hey, I'll never use this because it doesn't work. Don't dismiss that part. If you don't want what you do to be theoretical and go out there and help patients, that part is probably our next frontier, something we are actively working on. So anyway, look, it was a general talk. I do hope that I was able to bring your perspective on someone who does this kind of work, but also as a clinician. And also hope you bring you some challenging ideas, something that might interest more of you to get even more engaged. I assume you're already engaged in health, IT and AI, and see some of the potential in the future. These are some select references. Again, I would like to thank the organizers first for putting this whole thing together and for inviting me to speak. And I hope the talk was informative. I'm going to stop sharing my screen now.
Awesome. Thank you so much, Reza. I think we got a really unique perspective from both a clinician and what you're doing as the director of your lab. So we have a lot of great questions because of that, and they're from Discord. So I'm going to ask our mentors to unmute and try to monitor that question. So you guys can alternate and start asking questions on the Discord channel. So Sarvas and Isabella, are you guys here? Right. Yeah. All right. So you can start asking questions to Dr. Reza, and you can alternate with Sarvas.
Okay, I'll start with the first one. So the first one we have is, what do you mean by non-static ML algorithms in the clinic?
Okay, so I think you're referring when I was talking about how machine learning is implemented in the clinical workflow. So right now there are an increasing number of applications that are being cleared for use in the clinical workflow. And some of these are deep learning based. But you know, one thing we all know, one of the powers of machine learning theoretically is that it will continuously update and improve. That's not how things are implemented right now, right? So even if you have a deep learning algorithm created, it becomes a static software and is implemented. And indeed, I would go even further, and I see that as something that is more easily addressable. A lot of these are not even tailored to the site. And you know, we actually, Dr. Malek, he's a senior postdoc in our lab, had made, I think, a very nice review on, you know, how do you design AI projects so they're generalizable. And if you think, unless you have a truly very well and varied data set, you may even see a basis that, let's say you have a product and you want to implement in hospital A, you would at least want to check to make sure your data is represented in terms of noise and technical variations. Most vendors don't even do that. So for example, when I see some of these softwares not do nearly as well in a new environment, it's not even a surprise. So I want you to be aware of that because these are different mitigating steps. So one is to at least tailor. So let's say you have a package, but at least, and there are different ways of approaching. You can train a bit more, or there are some who have done things like confidence sample analysis. They do mathematical and statistical evaluations to see if the site the target site, if you want, data falls within the parameters of training data set you had, right? The other thing of live, that's not going to come soon. I'm just telling you, because as a clinician, we have a responsibility, first and foremost, not to do harm. So just the burden, forget, I'm the AI person, and even I think that that's going to need some really robust regulatory. But imagine the average person saying, oh, we're going to let this algorithm just do what it wants and mutate. Like, it's not going to happen now. In the future, though, I do think that is the gold, if you want, that is really the gold standard you're looking for. Imagine an integrated health network, right? Where everything is digital, where you have NLP evaluating the patient's medical chart, where you can actually tie a diagnosis to the pathology result and do continuous AI-based improvement. I mean, that's going to be the best thing. That's what probably is our ultimate goal. The only problem is also when you have a system like that, imagine all the points of security that have to be addressed. Their quality. So first, what if the AI algorithm goes crazy and does something wrong, right? So you need oversight for that. How do you monitor that the AI algorithm is functioning well? How do you also monitor that someone did not hack and and actually maliciously manipulate an algorithm? So the life changing is not come. I mentioned that maybe it's obvious to you guys. Sometimes people don't realize that, they think, oh, this is the AI coming and it's just doing whatever it wants. No, it's not like that at all, right? They're trained in a package, they're made into software, and they come. I don't know if that answered your question, but.
I guess I can say the second question now. Can we ever realize having a generalized automated ML model that can predict all types of cancer types in the clinic in the future? Or will they just be tumor specific?
It's a very good question, and I can only speculate. We just don't have enough data. I do think that it's going to be a tumor-specific component to it. The idea that all tumors are the same, this sort of goes against biology. I know sometimes there's always this desire to bring everything. I'm not sure if that's going to be the successful path. If you think, sometimes this question makes me think of sometimes even some more basic things. That kids are not little adults. So people who have done pediatric care, and whether it's imaging or not, know that sometimes the pathology in a kid just functions differently. So I would say you're gonna have a general component. By the way, 90% of the enterprise is going to be general, because a good part of it is not even going to be from AI. It's going to be basic informatics. Then you will likely have some sort of data processing. I know with deep learning, it's a little more controversial whether you should pre-process, but at least, especially if you're doing handcrafted stuff, and for the foreseeable future, you probably need some sort of harmonization, normalization, whatever you like. So all of that's going to be generic, right? You get an MR, you're probably going to process it in the same way. You're going to then, standardize it, so on. When it comes to the specific tumors, I think there'll have to be a site-specific, because tumors are different. Indeed, it would surprise me that you could have the same feature work. We have looked at that, where it's interesting, we do head and neck cancer, and we know that there are shared radiomic features between head and neck cancer and lung cancer. So it's not that there are not some features that will be useful, but I think to have a true precise precision therapy, this will have to be complemented with some tumor-specific features as well.
Thank you so much. And maybe Isabella, you want to ask the next question?
Yeah, for sure. Okay, the next one is, sorry, one second. In your opinion, what is the best way for institutions to train machine learning algorithms by combining their data? The data sharing restrictions make this very difficult. Is federated training the solution?
So federated training is definitely a very good possibility. By the way, just because you're doing federated learning, you haven't overcome all of the resistance to data sharing. I can tell you as someone who tries to set these up, but even that's not it. I think it does help, especially if you can be sure, because if the data sent in aggregate, so you can get to the person. Personally, I do think we need a lot more societal involvement, and that means experts like yourself. There's a lot of misconceptions. So I have 2 small kids, and I can tell you, they're not of an age to go on social media yet, although my daughter could go on YouTube when she was 8 months old. So you know how the new generation of kids are, right? So they're very different. What really worries me is what they're going to post on social media, much more than any weird thing some hacker may get by getting to their scan. So I do find the interest that people are so, and I'm not saying that they're not valid concerns, but this idea that there's so much greater concern towards the use, whereas every day AI has been with us for how long? I don't even know how many decades. I mean, how does Google know what we think or what we order? I mean, and this is where I think sometimes having experts at least calibrate that will help. I personally think, but it's a personal opinion, we're in a public system. We are probably one of the best places to make an argument where, wait, look, society pays for this, so society has a right to benefit. And, we should come with, like, it is amazing. If you think, what are the advantages of public healthcare system? A lot of them are overrated, right? In practice, they're not present. But if you think one that should have been is that less silos, because now you have one curator theoretically, right? At least it could be. You have one payer, you don't have all those issues. So I actually think some of these fixes should be legislative, that you can imagine a well-working state, you know, and I know we may be far from that, but would have a public system where they have well-controlled ways where data can be managed and bring value back to the population. Now, the idea that, again, profit from this is very controversial, but then I would ask you to say, so what, you want that to be wasted? Or how about all of those people who can't even get access to a family physician? And that's probably 50% of the Quebec population here, right? Because we are going by some theoretical idea. So look, data has value. I'm not saying let's just sell data, but I think in a system, I think that's probably the best fix. Sure, we can use federated learning, but I can tell you the obstacles, that's not going to address everything. We still don't know if it works as well, it might. And some institutions still don't have this habit of sharing. So for those of you who are a little more activists, I would say be practical and try to fix those. Always take into account security, by the way. I think we have to kill the misconceptions of what is the risk. Because there's a risk in everything, right? I go in my car, there's a risk I may get in an accident. So well, at least I don't want to live in a bubble. I don't know about you. So the thing is to inform the public, engage them, break this idea that AI is some Terminator machine that's going to come, because it sounds funny to you, but you will be surprised how AI is perceived. And that is translating into restrictions and legislation. So I think we need to have a little more openness there about how you can secure it, but how also they should be opened up because it could benefit the very people who are afraid of it. So that's probably my thing. Unless we break those, it's not going to fix. And by the way, let me tell you what's the other scenario. The big health IT companies, there are some companies that know how to break traditional models. And at the end, this is what we are. Healthcare is largely a business. You think you're going to block it this way. If I were, and look, there are people at Google are much more smarter than I am. I imagine whether it's Amazon or Google, they're thinking we're going to own a series of clinics. We're going to have all the data, and we are going to have these algorithms. Now, if the public system can catch up with those, guess what? Those will be proprietary because that's how they were designed, and it's going to come anyway. So I do think we need a little more, we need to be a little more changing. Healthcare is very static. I think we need a little more public engagement to make them understand the risks. We should address those risks, and we should open up the system. Otherwise, you're not going to get things that work.
The next question, it's about sampling bias in pathology. Could you specify some more examples and how can we improve?
In pathology, sorry, just to clarify, is this pathology like digital pathology, or you're talking about based on image pathology in a general sense of disease?
I'm not sure. It's an anonymous question. That's all what they wrote.
Okay, so look, in pathology, some of the examples we gave you. So a lot of these are pilots, right? But for example, in a brain tumor, there are studies showing, you can have 80, 90% of accuracy in predicting certain molecular phenotypes. Now, if you can do this in a generalizable way, of course, you're going to affect treatment, right? If you can predict that someone may fail, let's say, immunomodulatory treatment. So there's tons of examples there. Almost in every disease, you want to take in the head, neck, body, pancreatic cancer, all of that is there. A lot of this though is in small data sets, and really not in a way that someone can say confidently, oh yeah, I'm going to not give this potentially life-saving medication to our patient. This is why I think it's important the next phase, we know there's potential there, is to come up with things that give sufficient confidence that we can use them in clinical. And that's a high bar. Again, think of your family member, right? There are treatments that are approved. So now you're going to tell someone, let's not give this approved treatment because our AI predicted it doesn't work. So that's the bar. And I suggest you want to do impactful things, that's the next phase. And part of that is solving the small data set problem. In pathology, there's a whole other potential. Actually, we do our lab does some, pathology slide analysis. Pathology first, traditional pathology slides were actually slides on glass, right? That's probably going to become digital fully, I'm guessing, the next 5 to 10 years. Already things are being digitized, but not in a routine way. That's going to come. That's going to open that whole data set. Just like imaging, pathology is a diagnostic field. So now once you have these slides, of course, people are creating algorithms to help us diagnosis assistant, right? Analyze the whole slide, help classify tumor, probably start predicting things that it didn't. It actually becomes, if you take away the first step, it becomes very similar to us. So you can do a lot of things we do in imaging, in pathology. The only difference, of course, is pathology is either via biopsy or after you have already taken a tumor out. And in that sense, we'll have a different role. For example, some of the things we want to do to guide, let's say if someone doesn't need surgery, it is really only useful practically if they know that before the thing is taken out, right? So that's where imaging comes. That's where more precise, non-invasive imaging could be of value, maybe coupled with AI and biopsy analysis, right? In pathology, it'll be different. Okay, you take the tumor out, but now maybe you can use the slides to predict a phenotype you didn't recognize that's going to have a different outcome, different probability of recurrence. So this is the way I see that spectrum.
Okay, the following question is, what can we do to improve bias in general when choosing data for our cohort? And as an example, for the study of differentiating pseudo from true progression in GBM patients.
Okay, so that's a very important question, as you know, bias is a major issue. So there are basic things you can do. First, I think, for example, so you talk about pseudo-progression, you're likely doing MR. More and more people are doing some pre-processing to at least standardize. So try to use different scans. It causes challenges. See, it's almost the opposite of thinking the way we do a lot of basic science. And this is sometimes where the challenge is, by the way, even with grant agencies. If you look at the traditional, let's say, molecular study or a lot of clinical trials, what do? They narrow the population, right? Oh, we want no confounding. I think with AI, it's completely opposite. You want to mix data sets because, otherwise it's not going to work. So within the institution, make it varied. Use, if you have data from different magnet strengths, mix them, but account for them, because we know, for example, MR magnet strength will affect radiomic features, right? Have different readers, but ideally try to have multiple institutions. Now, something like pseudo progression in a way is a bit easier than a generic diagnosis because it's already narrowed if you want, but those are the things. Take care of the technical factors. And lastly, with pseudo progression and tumor, how good is your gold standard? So when you're going to tell the machine, this is not recurrent, and this is, are you sure? Because the way a lot of these things are done, they're assumed, again, these misconceptions that in medicine, things are working based on 100%. Actually, not at all, especially not in that domain. I can tell you, a lot of times the experts have doubts, right? So, and in the long term, maybe we have to tie this to something that we don't have doubt about, like survival. So I think that's what you should do. If you can get multiple institutions, geographic variations theoretically. So if we go beyond, because there may be genetic factors that are more, more concentrated in a certain area that may affect it. So let's say the ideal experiment would be maybe a couple of sites in Quebec, some in the US, some in Latin America, some in Asia, right? To have real variation, but that's really a high bar. But we say just try. Right now, with that specific example, getting a large enough data set itself would be a challenge, but these are the things you would aim towards to try to limit bias. And we also do basic things, we obviously the age, the sex, gender, all of that, any info you have. Some places even use things like postal code. It's controversial with REBs, with the ethics boards, but we have told them the reason. Like, it's not like we want to, it's just because, again, sometimes, it's not everywhere, in some communities, the postal code may actually have relevance in terms of a certain, that group may be less ethnically diverse, and that has implications. I can tell you in Quebec, there's a lot of, if those of you, for example, study respiratory disease like CF, cystic fibrosis, there's a founder effect in Quebec. And some of these diseases, we actually have, we have been leading in the research because we have a lot of cases. But that has an implication for you as AI people. And this is why sometimes, and we have got the ethics board to accept things even like postal code, because you cannot assume that there is not a cluster there that is more susceptible, and that may be linked to the postal code. So I suggest you, and by the way, I also suggest, of course, do bias analysis for all these potential confounders when you make the algorithm.
The next question is, could you clarify what is handcrafted features?
So handcrafted features. So this is, look, some use it, not everybody uses it. But if you broadly think of features, and this, I like to distinguish that because quantitative features are not AI, right? So there's this whole thing called image biomarker standardization initiative. You like this field, I suggest you become familiar with that if you're not, because it's trying to standardize these very features. Now, what are the traditional features, right? So we talked about some. They're first order statistical. I didn't expand a lot because I thought the computer science crowd may know. So sorry, we also can only cover so much in a 45-minute talk, but to their first order statistical features like average, standard deviation, skewness, their second order statistical features, and then you have a whole host of other mathematical features, waveforms. But all of these, what do they have in common? They are usually designed by the expert before the experiment. So it's not like someone said, oh, I'm going to analyze the GBMs and come with this. Someone came, an expert said, hey, this is a waveform formula. It gives us this information. So handcrafted, generally we think to things that tend to be designed before the experiment by experts, and they produce a certain quantitative measure that is then applied. So it could be applied to a brain cancer, to a head neck cancer, right? So this is what I think of as handcrafted, and I like to separate that from the other major category that really became possible with deep learning. It's not that you couldn't do image analysis with classic machine learning like SVM, but let's be honest, the output just wasn't sufficiently good for that, right? They're good as a prediction model. Let's say to make a prediction model with extracted features, the image analytic capabilities were limited. Now with deep neural networks, we know that you can actually really get very accurate models if you have large data sets, right? You see that outside of medicine. Now, the difference with these, so these non-handcrafted, or if you want, essentially, I think of deep learning, so deep extracted features, these were not designed by an expert generically and applied to disease. The deep features, how do you make them? They're learned, right? They're not pre-designed, they're learned features. So let's say we come up with a data set of 100,000 brain tumors, and we classify these as pseudo-progress. So that's we wish, right? But let's have a little bit of optimism here, where we had this data set, we had pseudo-progression versus recurrence. Well, now you're not imposing any specific quantitative feature and extracting. You having the deep neural network learn the features and create an algorithm. So that's really the distinction I want to make between handcrafted, designed by experts, typically before the experiment, versus deep neural networks that are learned. And of course, one would have to assume that these are more pathology specific, right? Now, they may have generic use, but by default, these are going to be created from the pathology. So there are learned features based on an experiment versus designed before the experiment. I hope that clarifies. It's an important point.
Okay, the following question is, there are so many papers on various segmentation / detection, etc. Yeah. How do they actually translate into the clinic? Excellent
question. They don't, because everyone wants to do the exciting part. Even the funding agencies, right? It's one of the challenges with AI. The basics agencies think we are too applied. The applied think we are not applied enough. It's actually something that has to be worked out. They don't, and you know why? Because they're not practical. So it's not like we could, look, we know, let's take a hepatocellular tumors, right? We know sometimes they become necrotic, so they're essentially sterile, but they remain big. They may even get bigger. Now, of course, that's not captured with a two-dimensional measurement. But, and this is where the promise of radiomics and AI comes, but practically to segment get a volume is too time consuming. I'm just telling you. So as a health practitioner, you have a list of 50 scans. Some of these are urgent. If you take more than an hour, the ER doctor is going to be calling you. So where's the diagnosis? Is this patient bleeding? Do I need to transfer them? If it's not practical, it's not going to be used. Don't be too idealistic. It's good to be it's okay to be a little. Think of that part. That's where I actually think is very important for us. I think the other reason is, take Quebec, known for AI, right? Now, I think in health, if we don't start showing at least some benefit to the population, people are going to say, oh, this is just fancy science, right? Not going to affect me. This is then going to have implications in terms of people wanting to fund your projects. So I do encourage you to bring these. So right now, most of the segmentation in clinical practice, the only group that does it are radiation oncologists, right? Outside of that, it's not used routinely in radiology for diagnosis or follow-up. And I would argue this is largely a practical problem. Now, the good thing is, I think this is feasible. So you need to harmonize the systems, semi-automate. And the better news is, by the way, if you solve that step, in my view, you have already solved a lot of the obstacles towards doing the next level stuff. Because if you segment, then you can extract the features. I think that's probably the biggest bottleneck right now. So if you solve that problem, you also essentially set the practical stage for implementing other high precision diagnostics. So something to be worked on. Now, the good news also, some industries are making more and more vendor neutral software that integrates AI into our clinical work systems. Do not dismiss these. These are the things you need if you want these to come out of the lab and into routine clinical practice.
Awesome. So we have one last question, which has multiple parts. Maybe Sarvas, you want to start that?
So the first part is, what sort of evidence do you think is going to be necessary to give clinicians confidence that the benefit in AI models or algorithms?
Well, I think, so that look, for the average clinician, so let's take out experimentation. I think we have to do trials the way we do with other devices. And you have to get them FDA cleared. As a physician, you have discretion in what you use in your practice. Actually, you have a lot of discretion. But if you want to do something institutionally, you need to reach the bar for FDA. So right now, I can tell you how they are because we are aware of different AI trials. So usually, obviously, there's data set requirements. It has to be a large size. It has to be varied. So you have to have good preliminary evidence. And then what they do then is that then they will conduct these. A lot of these are done retrospectively because they don't involve administrative. So you have to go through the medical device process. That's what you should familiarize yourself if you want to know what the bar is. In the future, you can also see with AI, you may have a period where you do prospective predictions without affecting care. That might help for some, right? And then once you can, then there's no question, then you can implement. But I would say the major bar, if you want this to be widely used, is FDA for US and Health Canada. But they're very similar in the requirements. They're not identical. So really, we tend to think of FDA. Something should meet the bar for FDA's medical device. They have slowly started to change because the traditional, there's some limitations of the traditional thing of assistant, this assistant devices in terms of computer software for detection. FDA is slowly changing this to come to AI, but you need a large data set to, and you need some to show that it works in different environments before they're going to be willing to clear it.
Okay, the second part of the question is, do we need to apply the same standards as we do, for example, for drug development with prospective trials?
Very good question. I think so. Look, in some ways we have the advantage that, but yeah, actually that's the way I see it. I think we have a lot to learn from the drug industry, from the medication, from the pharmaceutical industry in terms of how they conduct it. If you go back many years, for example, medication trials are very standardized and regulated. Why did they do that? Because early on, let's go, 60s, 70s, people were conducting these studies. Oh, this drug does this. Now, then they would come and regulate, and they all had these flaws. They had biases, problems. And then what people had to do, they had to repeat these. This is why they came up, by the way, by these very clear structures, randomized trials. I think in AI, we really, in a way, there's some differences, but we need to learn from that. The regulatory process needs to be standardized, and this is being done, especially imaging is very active. So I know, for example, the American College of Radiology is very engaged with FDA in standardizing these. But exactly, I think we should almost have templates of how do you do. Now, there are efforts, as you know, there are more and more templates being developed for what's a machine learning study. I think at some point, We need to come with a standard. You want a device, because that's what it is, to be diagnostic. This is how you should design. This is what you should address, the same way as we design randomized trials. And then we can decide, because this will have to be decided, how much retrospective is good enough, and probably have a prospective component. And I think if we do this, it'll be much easier for the average practitioner to accept these. And let's be honest, for the population to feel confident that these algorithms are safe and they're, and that they don't have a health risk to them.
Okay. We sure had a lot of really, really great questions. I think that's a testament to the fact that this was a very, very interesting and relevant presentation. So thank you so much for that. I'm going to share my screen again as we show a few closing slides.
Thank you. Yeah, I was just going to say thank you so much, Dr. Forghani, for your inspiring talk. I think that's why we need, that was a testament to, to show how important it is for us to be multidisciplinary and to think in multiple aspects and see what the challenges are in each field. So thank you so much for that. I hope you enjoyed giving the talk, and I also hope you enjoyed answering the questions.
Thank you again for the invitation, and for all of you in the computer science, informatics, medical physics, engineering fields. There's a future for you. There's a bright future. The use is only going to expand. The only thing I can encourage is, and we welcome that, we got to familiarize you with healthcare, but you're going to be a key players, in my opinion, in future healthcare delivery. So just keep at it.
That's good to hear. So we want to. Oh, okay. All right.
All right. So our sponsors are Transmedtech, McGill, our own medical physics department, Alpha Tau, the Jewish General Hospital, Comp, and Gathertown. Thank you to all of them for helping to make this possible. And of course, a very big thank you to our team, Marie, Sachin, Elena, Zachary, Hossein, Elena, Juan, and Milosh. And of course, our supervisor, Dr. Enger, for helping us to put on these events. We couldn't do it without them. And now we have an opportunity for you guys to come and socialize with one another. We know since this is a virtual event, it's not like you're going to walk into the lobby and get a chance to talk there. So instead, we've set up this Gathertown environment where you guys can chat, debrief about the presentation, network, or whatever you like to do there.
Yeah,
we'll be there too for a while.
And we'll just make some announcements on the next slides about what's coming tomorrow. And yeah, follow us on social media. Maybe go to the next one. That
was it.
Oh, that was it?
Yep.
All right. So tomorrow we're gonna talk about ultrasound imaging and incidence segmentation using MaxCar CNN. And we are going to have Dr. Peter Watson, who is a diagnostic medical physicist at the McGill University Health Center, who is also my own professor from last semester in my diagnostic radiology class. So he's gonna come and give a primer on ultrasound imaging, followed by Luca and myself talking about a very popular instance segmentation neural network architecture called MaxCar CNN. And I'm going to give the high-level introduction on how the architecture works and how you can familiarize yourselves and understand how to read sort of like an architecture figure. I'm going to foreshadow what Luca's going to talk about later on for the code. And then he's going to tell you a little bit more about, walk you through a worked out example of a MaxCar CNN to nucleus segmentation. And in last week's assignment, we actually also had a semantic segmentation example on ultrasound imaging. So I'm going to briefly touch on that as well. That was thanks to our mentor, Basu, to give that. And then maybe we can also foreshadow a little bit about next week's presentation. Luca, if you go to week 6 of our website, we're going to have 3 speakers next week. André Diamant and Martin Vallier and Professor Chris McIntosh. So we're going to have three of them. I had the privilege as an undergrad to have worked with Martin and Andre, and it's great for me to see that they're doing fantastic things now. So I'm really glad to have them here to talk. Andre's the CEO and founder of a startup company called Ray Oncology Solutions. They're growing and doing really great, so you should check them out. And Martin has recently become an assistant professor at the University of Sherbrooke. And then Dr. Chris McIntosh is going to give a presentation next week about their newly published paper in Nature Medicine as well. So we look forward to seeing all of you there and next week, other than tomorrow on Sunday. So thank you so much. We're gonna probably migrate to GatherTown now.
Yeah. Again, if you didn't get a chance to do the assignment Yujing mentioned, it's on the Google Drive that we've shared with you many times. You can find the link in the announcements channel. I've shared the link to the GatherTown meeting already. We'd be happy to see all of you there. We're always happy to interact with our participants directly over GatherTown.
Yeah. We also want to hear about what we can do better. So talking to you directly is a great way to do that. So thank you very much. I'm going to stop recording.